I am Dr. Debasis Chakrabarti, and my co-speakers are Dr. Sirisha Senthil, Dr. Anil Mandal, and Dr. Siddharth from LV Prasad Eye Institute. So we would first invite Dr. Kadava Rajkumar to give the keynote address, and then we'll start our session.
Thank you, Dr. Chakrabarti. Good evening, ladies and gentlemen. It gives me great pleasure to come and address this gathering on a particular technique which I have modified for the last 8 to 10 years, and I have been using the same technique. The slides I'll show a few to give the rationale for this technique, and in the middle I'll show you a brief 3-minute video of what I practice. And at the end I'll just conclude with a 1-year result and 5-year result of this particular procedure. And I'll tell you why it has sort of impressed me to just continue with this type of procedure. Can you adjust that, please? Slideshow. Thank you. As you all know, Keynes devised the procedure of trabeculectomy way back in 1968. At the moment, there are numerous non-penetrating procedures and MIGs that are evolving every day. But still, the gold standard for glaucoma surgery is trabeculectomy, as this whole session talks about the same. Now, you've all heard of Penkor mentioning to us the standard procedures, how to practice safe trabeculectomy. In the past, most people used to do LIMBUS-based trabeculectomy, and they had a lot of problems from LIMBUS-based trabeculectomy. And therefore, the method of a large treatment area with mitomycin, posterior flow of the aqueous, and a large diffuse bleb was thought to give better results with a better-looking bleb. And that was how, in Moorfields, Professor Penkor devised this particular technique. But there are problems with that too, because it's not very easy to attach the conjunctiva to the cornea and expect it to heal perfectly every time. There can be problems when the stitch becomes loose there and you get leaks like this, for example. Or you could have the bleb, which if you have tried to attach it to the de-epithelialized cornea in order to try and get a good adhesion, then the bleb can start migrating onto the cornea, which can cause problems of bleb dysesthesia, contact lens intolerance, and so on. Well, it can cause astigmatism. If it rides onto the cornea, it can itself cause astigmatism. Now, comparing the other method of trabeculectomy, which is the LIMBUS-based trabeculectomy, there are problems with a ring of steel forming around the bleb and reducing the surface area for drainage. So bleb failure can occur with that. Further, because of the reduced area, the bleb itself will start distending like a balloon which is pinched, and you get what are called cystic blebs, which are prone to leaks on their own and then susceptible to infections, blebitis, endophthalmitis, and so on. So those were some of the disadvantages of the two techniques. So can there be a third approach then, which can combine the advantages of both the techniques, but perhaps reduce the disadvantages? And then I thought about this third way, where you do leave a small frill of conjunctiva, 0.5 to 1 millimeter, above the limbus. And it can be done under topical and subconjunctival anesthesia, which I've never used subtenon, peribulbar, or retrobulbar for the last 8-9 years. It's all done under subconjunctival and topical anesthesia. Well, I just briefly go through this video and describe what the procedure is. I must acknowledge my registrar, Mr. Rashid, who made this video. You start off with making a tiny incision just about 0.5 to a millimeter above the limbus with a vanus. And in that opening, you suffuse the subconjunctival and subtenon space with a local anesthetic. A 2% lidocaine would suffice, about 1.5 to 2 mils. and raise a sufficiently large bleb. What it does is it slightly paralyzes the superior rectus, paralyzes the top where you're operating, paralyzes the top portion of the iris. So when you do the iridectomy, the patient doesn't feel any pain whatsoever. Further, because the superior rectus is slightly paralyzed, they just keep looking down. It's on a rare occasion where the patient has some sort of a gaze palsy where you can't make them look down. You may have to put a stitch and pull the cornea down. I don't even put a corneal suture for these patients. Just ask them to keep looking down, and they do perfectly well. The important part here, as you can see, is I take the scleral flap at least a millimeter above the conjunctival frill. And we prepare the flap as you all do, and I won't need to elaborate on how to prepare the flap, just to suffice it to say that I don't extend the vertical wounds on the side right up to the limbus, so to prevent any leaks in those areas. Now, obviously, we have prepared the bed, the subconjunctival tissue, with the mitomycin, and once the releasables are all inserted, as you can see, there are 2 releasables and a fixed suture to the flap. I use either a figure of 8 or a purse string stitch to stitch the conjunctiva on both sides, or you can even use 3 mattress stitches. The importance of this is you stitch conjunctiva to conjunctiva, so there is no difficulty in doing that. Most of us are used to doing that, and it's quite easy. But in spite of all this, you still get leaks because of some tissue erosion, some suture, this thing. So what I then tend to do is I run a 10-0 Vicryl as a continuous basis from one end to the other. So there is a double suturing here. And the whole procedure under topical will take about 35 to 40 minutes at the most. So this illustrates the video. We'll probably move on to the next slide. That's where we finish. Right, this is a finished hybrid trabeculectomy. As you can see, there is absolutely no leak from the wound point. You can test it with fluorescein, and you can see that the bleb has been burped, and there's a very good bleb on the top. This is just to show you about a month to 2 months after the hybrid trabeculectomy. You can see the releasable stitches, and you can see the stitch line about 0.5 millimeters above the limbus. On the left-hand side, the same patient a year down the line. On the right-hand side, the same patient 5 years down the line. A very diffuse bleb, no major cystic problems. So we did an audit of this procedure for a set of patients for a duration of 2 years, whomever I had done on this particular technique. At about 54 patients, we analyzed the data. And you can see most of them were primary open-angle glaucoma. The second most common group was normal tension glaucoma. Well, 100% of patients were previously on topical medication, and they were on average of 2.6 drops before they had this trabeculectomy. And the indication for trabeculectomy was either the pressure was too high, or they were not tolerating the drops, or there was some progression in the field defect. Well, at the end of 1 year, you can see that nearly 97% of the patients achieved pressure less than 18, and a significant proportion of that were less than 14 millimeters of mercury. I tried to compare this with my colleagues in the UK, Professor Shah, who works in Birmingham, and James Kirwan, who works in the south of England, who has actually published a multi-center retrospective audit of trabeculectomy in ophthalmology a couple of years ago. And you can see that our rate for high-pressure glaucoma and normal pressure glaucoma compares very favorably at the end of 1 year with the hybrid trabeculectomy, which is HT. Long-term outcomes, what did we look for when we tried to analyze the patients? We tried to analyze the same group of patients. We could only get about 30... Oh gosh, sorry. I don't know. Can we switch this? We could only analyze about 30-odd patients over the 5-year time because there is either loss to follow-up or even death that can intervene to not get the whole nodes. And the interventions we were looking to see were there any suture manipulations, how many bleb needlings, and how many required cataract extractions, and was there any significant complication. As you can see, the intraocular pressure distribution preoperatively is all denoted by the purple color, whereas postoperatively most of the pressures are around 10 or less. And that is the Kaplan-Meier type of curve that you can see that, the mean pressure we started off was rather low at 19 millimeters of mercury for the whole group, and it came down to 10.5. And that is the percentage in the number of eyes which we could manage to follow up for 5 years and more. At the end of the study, you can see nearly 28 out of the 30 attained pressures of less than 15 and continue to stay the same way. And that is just to show the number of people at the end of final follow-up with qualified and unqualified, where they were not with any drops for the unqualified, and they were using 1 or 2 drops for the qualified. The visual acuity itself was quite excellent. Initially, it was 27 out of 30 who had a vision of greater than 612, but even at the end of 5 to 6 years of study, 24 out of the 30 had very good vision above 612. Some of the others who did lose vision, they developed age-related macular degeneration. One developed glaucomatous optic atrophy end stage. One developed a bit of corneal decompensation, which got corrected by a corneal transplant after the cataract surgery was done. 6 of these 30 eyes required suture manipulations, which is 1 in 5. A bleb needling, 1 in 3 to 1 in 4 needed needling at some point in time between 1 month to 70 months. And nearly a third of the patients underwent cataract extraction, which is a common thing which we tell all our patients who undergo trabeculectomy. There were 0 cases of endophthalmitis or blebitis. One patient did have significant hypotony in 3 weeks' time because of severe leakage, but we could easily stitch back because, again, this affords us to stitch the conjunctiva to conjunctiva back, and we achieved a better result at the end of it. So in summary, it has excellent success rates, which I have shown to you. Nearly 90% are able to maintain pressure of less than 15. Visual acuity maintenance is also quite good. And the advantages of hybrid trabeculectomy is that it can be done even in some degree of conjunctival scarring, but obviously that's not the good indication for trabeculectomy anyway. Suitable in prominent brow and anophthalmos. It can be done without a trained assistance. It can be used in phacotrabeculectomies, which I showed you the example of. Requires lesser skill than fornix-based closure. Preserves limbal architecture. Because you don't put mitomycin onto the limbus, you may not destroy the stem cells. You retain the stem cells, which are of use to us at a later stage. Doesn't cause significant foreign body sensation. It allows for subsequent surgery and allows rigid contact lens wear. It allows for a large diffuse posterior drainage, which all the fornix-based flap will do. To avoid the complications of peribulbar and subtenons, where you cannot predict if they can get a bleeding or not, you do the anesthesia under microscope, and you can avoid that. It combines the advantages of fornix-based and limbus-based, as I showed you, and it reduces the wound leaks needing intervention. Even if you get a leak with this, you can observe it. It'll heal on its own at the end of 4 weeks. And the other things I have already mentioned to you. Thank you very much.
Please collect your Ready Reckoner 2017 from the kit counter. So that was the keynote address by Dr. Rajkumar. Thank you, sir, for your excellent presentation. And now I would call upon Dr. Siddharth, who would discuss the preoperative considerations while you are planning a phacotrab or SICS trab. Dr. Siddharth, please.
Ashish, now before you do it, you need to have some considerations in the mind. There has to be a final checklist before you actually operate, and there is some time between your surgery, when you see the raised intraocular pressure and you take the decision to operate. A very, very important thing to understand is that to choose between additional medications or an alternative and to choose between a combined surgery is the patient's decision. We cannot decide for a patient that 3 medications are enough, I'm not going to add a 4th one. So alternatives like pilocarpine, especially in angle closure, even in the presence of cataract, there's no harm in trying it. And some patients do prefer to have oral acetazolamide trial and then try it out. So the maximal medical therapy should not be defined on our notions. It should be decided on the basis of what the patient wants and is ready to comply with. Also, very, very importantly, one has to relook at the need for surgery again, because a filtering surgery is not a surgery that anyone can assure will be free of complications. One has to also differentiate between a minor spike and the risk of progression, and the risk of progression and the risk of a significant visual loss or blindness. So if we look at this graph, we can see here that most of the patients here, so this patient is very, very far from functional visual impairment. So even if there is a spike and there is a mild progression, and if he's an old patient, we don't need to go and necessarily do a trabeculectomy for this patient. However, if the patient belongs to one of these categories, you need to hurry up towards the surgery rather than wait for a progression after a spike. So it has to be customized decision based on the severity of glaucoma and the age of the patient. It is always better to under-promise and over-deliver. Don't tell the patient that you will get a 20/20 vision with a pressure of 10 millimeters of mercury and you'll never need to come again, because that's not true. You don't know how the astigmatism will behave, and up to 10 to 15% of patients need medications at the end of the first year in most of the series. So plus minus 2-3%, we are all about in the same area. You must also tell the patient that they may need some manipulations like sutural lysis, bleb massage, and may need to visit a little more frequently in the initial post-op follow-ups. Also let them know about complications that can happen with trabeculectomy, that the trabeculectomy can completely fail also in the long run and sometimes in the short run also, and they may need to get back to medications. So just like we do with all these surgeries. Now the pre-op considerations in general can be divided into assessment of glaucoma, assessment of ocular comorbidities, assessment of the systemic status, and the assessment of ease of surgery and the risk of complications. So there are patients who have very, very advanced glaucoma. Some of them can have a macular split, which is defined by one of the paracentral points in a macular program being depressed to 0. Now, these are patients who are at a very high risk of wipeout. And you have to let the patient know that they are at a risk of high wipeout, and they may also lose the entire vision that they have in case of a wipeout. How to avoid wipeout? You have to avoid a sudden lowering of intraocular pressure. So it is important to achieve the best possible sustained intraocular pressure control as much as we can preoperatively, even if it is temporary. So adding tablet acetazolamide, oral glycerol, or giving intravenous IV mannitol is important so that you don't enter an eye when the pressure is very, very high and create a sudden hypotony. It is also important to avoid hypotony in the post-op period using multiple releasables or releasable and tight sutures and planning for sutural lysis is a very, very good way of doing it. Though it's not completely proven, but a lot of people agree on the fact that peribulbar anesthesia is likely to cause more wipeout by causing vasoconstriction, orbital compartment syndrome, and pressure on the optic nerve, and reducing the blood flow to the optic nerve. So these are patients where we want to do topical anesthesia for sure. Of course, it's a very, very good idea to use some subconjunctival anesthetic along with the topical. It cannot be purely topical. Again, it is better to avoid adrenaline in this anesthesia completely because it is known to cause vasoconstriction, and hyaluronidase can cause orbital compartment syndrome. So using minimal amount of a long-lasting anesthetic like bupivacaine is a better alternative. Patients can have infections, and in case of any infectious foci, you need to wait for that to be taken care of. Some of the patients have been using conjunctival topical medications for a long time, and they are known to have a subclinical inflammation in the conjunctiva with more and more lymphocytes pouring in. So there it is a good idea to use a short course of steroids if you can wait and you're doing the surgery for a cataract and not necessarily for an intraocular pressure that is high. Patients with significant surface allergy and generally congested eyes are also not very, very good candidates for direct surgery. Short course of weak steroids will help. There are certain conditions where hypotony is bad. Patients who are on multiple anti-glaucoma medications, patients who have large globe and thin sclera, patients with uveitis, high myope, they are not only prone to have hypotony because of ciliary shock, but also the hypotony in them is likely to last longer. In certain patients, hypotony can have severe complications like non-ophthalmos, where it can cause uveal effusion, which may become very difficult to treat. Patients with retinal detachment, where the retina can detach again with a choroidal effusion. And patients with severe angle closure and plateau iris, who are more predisposed to aqueous misdirection. Patients who have had aqueous misdirection in the other eye is another group of patients where you should avoid hypotony. Of course, you want the diabetes to be controlled well so that the healing is better and there is less chances of infection. And hypertension control is very, very important because it is also a predisposing factor for suprachoroidal hemorrhage. Anticoagulants must be stopped because they increase the risk of bleeding. You must also look at the general capability of the patient to lie down and whether the drapes can be applied on the patient or not, because there are patients who are claustrophobic and we realize only on the table because we don't ask for it. We should not leave it for the time of surgery. There are patients who are predisposed to have a failure of TRAB, and these are very, very well-known indications like young age, uveitis, neovascular glaucoma, long-term multiple medications, severe conjunctival manipulation of SICS or a TRAB, and presence of significant trauma. You need to be prepared. When you have to do a TRAB, you have to do a TRAB or a combined, but you need to be prepared and take extra precautions for them. Any intraocular inflammation needs to be well controlled, and for posterior uveitis, intravitreal steroids may be a good option. For neovascular glaucoma, control the ischemia as well as you can with injections and PRP. It is important to locate the area of the most mobile conjunctiva if the conjunctiva has been disturbed before, and by testing the mobility with the help of a cotton bud. Just as I mentioned, for reducing the risk of hypotony, maculopathy, choroidal and suprachoroidal hemorrhage, use agents to reduce the intraocular pressure in advance to the surgery. With proper planning and timely interventions, we can always ensure that we do the surgery well, and this will help us in having an ideal trabeculectomy with or without a combined surgery. Thank you. I welcome Dr. Debasis now.
Evaluation. So after you have evaluated the patient, you are planning surgery, either SICS TRAB or phaco TRAB. Before that, we can discuss a few practical anatomical points which we often tend to overlook while we are planning the surgery. No financial relationship to disclose. So knowledge of both the internal and the external anatomy of the limbal area is essential for successful incisional surgery. As we all know, trabeculectomy is a girded partial thickness filtering procedure performed by removal of a block of peripheral corneal tissue beneath a scleral flap. In a strict sense, the term trabeculectomy is inaccurate. This is according to the American Academy of Ophthalmology, because the procedure usually involves a peripheral posterior keratectomy rather than removal of trabecular meshwork. Now, although there are various theories as to the IOP lowering effect of trabeculectomy, it's usually considered that this effect is achieved by the generation of a fistula that connects the anterior chamber to the subconjunctival space. So removal of the trabecular meshwork is not required to achieve this result. Now we'll discuss the points step by step. So the first point in the surgery, the first step in the surgery is a proper exposure of the area from the limbus to the superior fornix. And here, there are two methods of exposure. One is a corneal or a limbal traction suture. This can rotate the globe down, providing excellent exposure of the superior sulcus and the limbus. Or else, a superior rectus bridle suture can be used. It has the same effect, but is more likely to cause postoperative ptosis and subconjunctival hemorrhage. So while holding the superior rectus forceps, we use this forceps, and the forceps we can remember is designed in such a way that if we keep this bend at the limbus, automatically the tip will be at the insertion of the superior rectus because this distance is 7.7 millimeter. Then the very important step of creating the conjunctival wound. It's important to remember that the conjunctiva and the tenons are not exactly inserted at the same place. The insertion of the conjunctiva onto the cornea is variable, and often it's more anterior than expected. On the other hand, so far as the tenons is concerned, approximately 1.5 millimeter from the limbus, the tenons capsule fuses with the underlying episclera. So there is a gap in insertion. And the key of successful conjunctival dissection, so that we can go beneath the tenons and dissect the conjunctiva tenons complex as a whole, is to free the tenons fascia from the episclera like this, and then grasp the edges of both conjunctival and tenons when separating the two layers from the rest of the underlying sclera. What I mean to say is you have to hold with your non-dominant hand and non-tooth forceps the conjunctiva and the tenons together and then go beneath this layer. Also, it's important to remember that protecting the edge of the tenons is important, for it serves as a gasket to prevent leaks at the limbus during the post-operative period. So you should take care while inserting the scissors below this. Try to avoid a radial cut of the tenons here, because the tenons acts as a belt or a gasket, and this helps to prevent post-operative leaks. Then after we have dissected the conjunctiva, we elevate a superficial scleral flap. It might be triangular, it might be rectangular, does not matter. But very important is to identify the anatomy here, the anatomy of the surgical limbus. So the surgical limbus or the blue zone, it's a 1.5 millimeter transition zone. And here the structures from posterior to anterior are the sclera, the scleral spur, the blue zone, and the cornea. Now, how to identify the scleral spur practically? The scleral spur is a white glistening band located posterior to the blue zone. This anatomy, however, varies widely and must be determined intraoperatively. And because of the angular orientation of the cornea and the sclera, it has been seen that a perpendicular incision made at the sclerolimbal junction would enter the anterior chamber at the junction of the anterior trabecular meshwork or Schwalbe's line area. And the Schlemm's canal is located directly anterior to the spur. So the clinical significance is, while dissecting the deep scleral block, you should not move too far posterior below this zone of the scleral spur. If you do that, there is a chance of inadvertent injury to the ciliary body and the chance of bleeding. So just reiterate how to note the scleral spur. So when we elevate this partial thickness scleral flap, the external landmark of the scleral spur is a circumferential ring of white scleral fibers, which is identified in stark contrast to the juxtaposed longitudinal fibers of the scleral bed. So this is a sclera. The fibers are located in this direction. The scleral spur here, it has a more glistening appearance, and the fibers are oriented circumferentially. Then about the scleral flap dissection, if a fornix-based conjunctival flap is used, it is best to avoid dissecting the flap anteriorly too much into the clear cornea. We can go 0.5 millimeter or so, but too much of anterior dissection might facilitate early wound leakage. And there is no advantage in extending the block posteriorly into the sclera. The risk of bleeding from the iris root and the ciliary body is greater. And while making the sclerostomy, it has been shown that aqueous drainage is generally not restricted by the size of the sclerostomy. However, the sclerostomy must be large enough to avoid occlusion by the iris, but small enough so that it is overlapped on all sides by the scleral flap. More overlap, a thicker flap, and tighter sutures are generally associated with less flow, and the converse is also true. Then coming to the last anatomical point we'll discuss, which is during the iridectomy. So the iridectomy is performed to reduce the risk of iris occluding the sclerostomy and to prevent pupillary block. Care should be taken to avoid amputation of the ciliary processes or disruption of the zonular fibers or hyalid face. So we should try to do the iridectomy in one step, because after making a partial iridectomy, if we try to catch hold of this iris tissue, there is the chance of inadvertent injury to the deeper structures. So that is all about the anatomical relevance of this surgical limbus with relation to trabeculectomy. I would now invite Dr. Anil Mandal to discuss the surgical technique of SICS trab and how to manage SICS trab in difficult situations. So he has 2 talks. He will combine both these talks together. Dr. Mandal, please.
Yeah. Thank you. Good afternoon, everybody. What I'll do, I'll present the results of combined manual small incision cataract surgery with trabeculectomy, a small series done by me. Before I really come to the series outcome, whenever we plan to manage cataract and glaucoma in a combined surgery, we'll have to realize that cataract surgery requires a perfectly sealed incision or suture, suture or sutureless. It should be perfectly, the wound should be in a situation that it will not leak. Compared to that, filtering surgery requires wound healing or suturing in a way that it should not close permanently, it should leak. So it's contradictory. And when we are combining the two, we'll have to be very careful. We want a controlled filtration and it will not create complication. My learning for combined cataract and glaucoma surgery has been initially in the years, residency period 84, 85, 86, in the form of trabeculectomy with intracapsular cataract extraction. We have seen results of that, associated complications related to that procedure. The technique improved. Then came the standard technique of extracapsular cataract extraction. When it was combined with trabeculectomy, the results were better, complications were less. The technique further improved in the form of phacotrabeculectomy. Definitely, probably the best technique in the management of cataract and glaucoma, combined surgery. I learned SICS trabeculectomy after I learned phacotrabeculectomy because in the institute where I am working, LV Prasad, we have learned ECC in All India Institute, then learned phaco in LV Prasad, then combined phacotrabeculectomy. SICS I learned after few years of my learning phaco. Naturally, phacotrabeculectomy experience is relatively, SICS trabeculectomy experience is relatively less, but I am working there for 27 years. The technique I'll present is a standard one, and I feel the results are comparable to that achieved in phacotrabeculectomy. The aim of our presentation in this slide is to determine the long-term visual outcome and intraocular pressure change in manual small incision cataract surgery with trabeculectomy and to investigate the complications. It's a small series of 130 eyes of 119 consecutive patients where 58% of the patients were having primary open-angle glaucoma associated with cataract and 42% had primary angle closure glaucoma associated with, cataract. Now, all these patients I am presenting had good intraocular pressure control with multiple anti-glaucoma medications, starting from 2, 3 to 4 medications, and was having visually significant cataract. Now, when we compare the preoperative IOP versus postoperative 6 weeks or 1 year, there was very little reduction of intraocular pressure compared to pre-op, because preoperatively all these patients were on multiple anti-glaucoma medication and pressure was under reasonable control. And that's the reason, although pressure reduction at the end of 6 weeks was 8.5%, at the end of 1 year was 13.4%, it's the question of how much how many glaucoma medications are required in the postoperative period in the long run. Number of mean anti-glaucoma medication preoperatively was 2.12 plus or minus 0.97, and anti-glaucoma medication in the postoperative period was 0.18. So there was statistically significant reduction in the requirement for anti-glaucoma medication in the postoperative period. When we saw the visual acuity improvement, mean pre-op versus mean post-op, it's calculated in log-mar. there was statistically significant improve in the visual acuity in the postoperative period at the 6 weeks and 1 year postoperative. So when we analyze the complications, number of complications, one each in buttonholing of the conjunctiva, postocapsular rent in one eye, Blevlik in one, and hyphema in one. So to summarize, number of complications were very little, and combined manual small incision cataract surgery with trabeculectomy is safe and effective. It gives good intraocular pressure control at 1 year postoperative, and continued follow-up also achieved the same thing, and it is associated with good visual outcome. I personally believe that it's a suitable alternative for phacotrabeculectomy in the management of combined cataract and glaucoma. However, I don't want to convey the message that SICS trabeculectomy is better. Wherever possible, phacotrabeculectomy is fine, but there are situations where the cataract condition is such, there probably SICS will have edge over phacotrabeculectomy. Very small pupil, difficult cataract, Rockhard cataract, total white cataract, hypermature Morganian cataract associated with glaucoma, all these situations. Can you present the video now? So what I'll present, an edited video of about 10 minutes, the standard technique I follow. Now, when the standard technique I follow, it means that this is the way I, evolved, and finally the stage at which I am in, and I am presenting that. Visualization. This is the maximum dilatation for this patient. It's a case of open-angle glaucoma associated with visually significant cataract. Fornix-based conjunctival tenons layer is made, and we are cauterizing the superficial, episcleral blood vessels. I give a straight incision approximately 1.5 millimeter from the, conjunctival insertion, and then the dissection is carried, and a side cut is made, and anterior chamber is entered with the keratome. I am trying to put viscoelastic under the pupillary margin and presenting some more viscoelastic because I wanted to create a space between the anterior surface of the lens and the iris so that I'll be able to do a reasonably good rhexis, and for that I want to carry forward the rhexis, which may not be visible to me, and it will be going, it will be underneath the iris surface. You can manage this with experience. In any difficult situation, I don't mind giving, little relaxing incision at 6 o'clock, or in most difficult situation, PI first and then keyhole iridectomy. Visco procedures are done, and superficial soft cortex is, you can see the technique of nucleus prolapse. So one edge is prolapsed, then viscoelastic is made, so that with the help of Sinskey hook, you can rotate this hard nucleus out of the capsular bag. Just rotate it out through the capsular, rhexis margin, and once it is delivered into the anterior chamber, visco expression, whatever technique one is comfortable for delivering the nucleus is fine, because here the incision size is reasonably large. Here I am pushing viscoelastic and pressing the posterior lip so that the nucleus will be delivered without any damage to the corneal endothelium. Then the procedure should involve removal of the cortex, superficial cortex, whatever is loose, and all the cortex from the capsular bag. Soft epinucleus is delivered, and then with the help of Simcoe's cannula, residual cortex is removed. I'm sure each of you have your own way of managing SICS. Whatever way one manages during his surgery can be done. It's the question of after placement of the lens, the trabeculectomy part of the surgery should be done very meticulously. Here is a situation, sometimes I use bent cannula to remove the subincisional cortex from the capsular bag. Fill the capsular bag with viscoelastic and placement of the lens. Here is a situation, even if foldable lens, there is no need to fold really because the incision is reasonably large and you can put directly the lens inside the capsular bag. Then the upper haptic will be rotated inside the capsular bag. It has gone into the capsular bag, and the next few minutes video will show how the trabeculectomy part of the surgery will be added and closure of the incision by two interrupted suture. Before the trabeculectomy part is done, the pressure inside the globe should be reasonable, otherwise there will be difficulty in removing the deeper block to complete the trabeculectomy part. Hold here posteriorly, give a straight incision, and then do the trabeculectomy as it is done in the standard way. After removal of the deeper block, peripheral iridectomy is done, and final suturing on the incision is done with two interrupted tenonylon suture. So we are making sure here iridectomy is done properly. Now ideally speaking, the base of the iridectomy should be larger than the deeper opening made, so that in the postoperative period, if shallow anterior chamber happens, the iris pillar should not come and block the deeper ostium made. We are just checking, seeing the apex of the peripheral iridectomy made, and then suturing. Here suturing is done just apposition of the wound, not very tight. And before that, viscoelastic should be removed. You can see the PI here, and I'm going through the PI underneath the iris and going to remove the viscoelastic very thoroughly. One more suture will be given here. The suture is rotated so that the knot is buried inside the tissue. It's by experience, just see how much is the pressure within the globe. If necessary, you can refill. If necessary, you can let some amount of ringa lactate or BSS to come out of the wound. And then the conjunctival suturing is done. You pull the conjunctiva and then tighten it, stretch it, and then through the deeper tissue here, take the conjunctival bite in a way that this will not slide even if there is movement of the glove or movement of the eyelid over the wound. This is a very simple technique. Once you have learned trabeculectomy and SICS, you can just combine like this. What I have learned and I have felt, I have analyzed my results that the technique gives equally good result compared to phacotrabeculectomy. I do not want to convey the message that phacotrabeculectomy effect-wise, intraocular pressure lowering effect-wise or the quality-wise anyway, less than this, but it gives very good result. What advantages it gives that with simple instrumentation, without using phaco machine, you can do equally good technique. And here is a situation, incision length does not matter because anyway you want a leaky wound and the closure should be done in a way that this stretches over the wound and whatever filtration takes place will be posteriorly directed. Thank you.
A very nice presentation of SICS trap by Dr. Mandal. We will now demonstrate the surgical technique of phacotrabeculectomy in routine situations. So after the superior rectus brittle suture, the important step is the conjunctival dissection. And as we have discussed in the anatomical part, the conjunctival dissection must be meticulous. So one should try to go beneath the tenons. So identify the junction of the insertion, insertion of the conjunctiva and the tenons. And with your non-dominant hand, hold the conjunctiva and tenons together and then go beneath these conjunctiva tenons complex. And you should also be careful so as not to make any radial cut to the tenons because the tenons acts as a belt. Sometimes it helps to make a little bit of hydrodissection below the conjunctiva so that this conjunctiva tenons complex swells up and then it becomes easier to go beneath. So after that, the important part is to go as far posterior as possible. So insert the tips of your waistcoat scissors as far posterior as possible so that you get a diffuse bleb which is more posteriorly located. So after we have made the conjunctival incision, we have to apply light bipolar cautery to any bleeding vessels in the area that we are planning the scleral incision. So it should be only light, you should not apply very heavy cautery. And then the mitomycin C soaked sponge is inserted below this conjunctival flap, taking care not to touch the edge of the conjunctiva with this mitomycin C sponge. The concentration and the time of the mitomycin C will depending on the type of glaucoma and the surgeon's preference. Personally, in most of the cases, I use 0.4 milligram per ml for a time of 2 minutes. And after the mitomycin C is washed, the surgeon now moves to the temporal part. So this is a two-side trabeculectomy. So we go to the temporal part and we complete the rhexis. The size of the rhexis should be slightly smaller than what we do in a routine phaco, so that in case there is a postoperative shallowing, the lens does not come out of the bag. So a clear corneal incision is made and the phaco is done. So one can use whatever technique one is comfortable with, maybe stop and chop, maybe direct chop, maybe divide and conquer method. But we should be very careful so as not to cause any damage to the posterior capsule, because if there is vitreous prolapse, the success of a successful phacotrabeculectomy definitely comes down. So we do a chopping of the nucleus and then complete the phaco in an uneventful way. So after the nucleus is removed, the cortex is aspirated. So this is the two-side trabeculectomy. It takes slightly longer time because you have to shift positions. But I feel the surgical results are better in this technique. And then the foldable IOL is implanted into the bag. The corneal incision should always be sutured. And then I shift superiorly and complete the trabeculectomy part. So it can be a triangular flap, it can be a rectangular flap. Triangular flap is what we have learned. It is easier to dissect, and routinely we do a triangular flap. So we are using number 11 blade to make the scratch incisions in the sclera. And then I am holding a LIMBUS forceps in the left hand and number 15 blade in the right hand and dissecting the superficial scleral flap. The thickness of the flap should be around 1/2 to 2/3, because if the flap is very thin, then the closure of the sclera might be difficult and there may be too much of aqueous leakage. So now we are dissecting this limbal surgical limbus. What we have discussed is the sclera posteriorly, the blue zone anteriorly, and then the clear cornea. So you can go slightly into the clear cornea. And then I put a 10-0 nylon suture at this apex and ask my assistant to keep this retracted so that I get a very good exposure of the limbal area. So with the left hand I am holding this scleral flap, and with the right hand I am dissecting the deep scleral block. So I personally use a Wieland's knife because it's very sharp and it's very easy to dissect under direct supervision. So a punch can also be used, but my personal preference is with this thing. And so the excision of the deep scleral block is completed with Vannas scissors, and then the iridectomy is done in one go. And then I gently tap the superficial scleral flap to ensure that I can see this red glow through this part. So here it comes. So the iridectomy is complete now. And then I close this apex with a single 10-0 nylon suture, 3:1:1, and bury this knot beneath the scleral flap so that it does not come out or poke out through the conjunctiva. Then I again go temporarily and remove the viscoelastic and trying to titrate the amount of aqueous that is coming out through this flap. And then the conjunctival closure. So this is 8-0 Vicryl. We use 2 wing sutures. Maybe you can put more if you feel you need more at the 2 ends. This closure should be watertight so as not to get any post-operative leakage. So drag the conjunctiva slightly over the limbus so that the conjunctiva itself acts as a suture. So these knots must be very tight. So the edge of the conjunctiva is firmly opposed to the cornea, and this prevents post-operative leakage. So this is the usual trabeculectomy technique that I follow. 2 other important steps that I would mention. One is the releasable suture technique. So this has helped me to cut down the rate of the post-operative hypotony. So I use a relatively loose apical suture and then put this releasable suture. So this comes out through this clear cornea, and then through this limbus I take another bite, and then through the edge of the triangular scleral flap through the left edge, and then the right I take the suture out. And then I take 3 or 4 throws and put a knot there, but very careful not to lock this knot, or else post-operatively, while you try to release the suture of the slit lamp, it will not come out. So just in one go, you put a knot and then cut the edges. So this releasable suture is really helpful because you can put a relatively loose suture at the apex and put a tight releasable suture. After 1 to 2 weeks, when there is some amount of fibrosis, you can release this releasable suture. So the other thing that I have seen is that despite meticulous care of the conjunctival suture at the two ends, sometimes there is leakage from this conjunctival edge. So this box suture technique is very helpful. So you pass bite through this clear cornea superiorly, come out through this conjunctiva, then through the other end, and tie a knot in such a way that the knot slips beneath the conjunctival edge. So it does not cause much of an irritation post-operatively. If it does, you can remove this suture later after a month or so. So I put one box suture here. So in the middle here, there is this releasable suture. Here I put a box suture and then another box suture here. So that the entire cut edge of the conjunctiva is firmly opposed to the cornea and there is very minimal wound leakage from this spot post-operatively. So these are the steps that I follow for a routine phacotrabeculectomy. So to summarize, meticulous conjunctival dissection. Rex is slightly smaller than the usual phaco. And a good closure of the conjunctiva help in a successful phacotrabeculectomy. So that is the end of this presentation. I would now invite Dr. Sirisha Senthil, who is currently the head of the Department of Glaucoma in LV Prasad Eye Institute, to discuss phacotrabeculectomy, because that takes care of any leakage through that, because you want flow through the main incision.
And what is the size of your triangular?
I do not use a fixed size, it's by practice only, but on an average it's around 2.5 into 2.5.
Wound is that the corneal wound it's valvular, it's a 3-plane incision, it's valvular, but the valve is very well opposed only when your intraocular pressure is certain level or above. So when you're creating a leaky wound superiorly, and if you don't suture this, there's a possibility that if you squeeze the eye, that the lip may open up and it's not self-sealed. So because of that, you don't have to tighten it, but just oppose the edges should be fine. Yeah. All right, so we have a very beautiful demonstration of SSCS trabeculectomy and phacotrabeculectomy step by step. Some difficult situations in phacotrabeculectomies that I will discuss about. So it's not uncommon for us to see eyes like this, where the glaucoma is most often managed medically. So many of these patients, if they have an uncontrolled glaucoma, they undergo trabeculectomy. And all of these people over a period of time develop cataracts. And we know that post-trabeculectomy, the chances of cataract increasing is also on the higher side. And it's not uncommon to see these kind of blebs, and we have to manage cataract in these eyes, or sometimes you have situations like acute angle closure where you have a lot of problems with the iris and endothelium is compromised, and we have to do a cataract surgery in those eyes, or sometimes combine the two. So a few tips to remember is, if you have a patient with a previously filtering bleb, and if you have to go and do a cataract surgery, it's not difficult to do. We can go ahead and do whichever technique is comfortable with you. Most often it is a clear corneal incision, because if it is a superior bleb, you don't want to touch that. Or it can be a temporal, either a clear corneal or a temporal SSCS if you're comfortable with that. Usually if you do a glaucoma surgery, and if it requires a cataract surgery, if you think it would require a cataract surgery within a couple of months, it's better to combine the two. So preferably, if you have to do a cataract surgery, you should be able to give a gap of at least 6 months, so that the inflammatory process or the healing process is completed, and your cataract surgery is not going to fail your filtering bleb. So most often we encounter pupils that are very small, either cases with pseudoexfoliation or the ones with pilocarpine, or just the age itself. Older people, you have smaller pupils, shallower anterior chambers in angle closures. And since we wait in these patients, especially if they are one-eyed patients, we tend to wait until they are visually debilitated. And at that situation, I think we also end up having very hard cataracts. Pinky is something that we need to avoid if you are using a peribulbar block, and make sure that your bleb is not ruptured or there is no problem before you take it up for surgery. So just a small video to show you the kind of precautions that you would need to take. This eye this patient has a very, very thin cystic and a filtering plaque. You can see the large scleral defect that is there. There's no superficial flap also which is covering that. Most often in a situation like this, I would actually prefer to do a combined bleb repair with a cataract surgery. If I would use a scleral patch graft and then remove this abnormal conjunctiva here, thin conjunctiva, and either do a conjunctival advancement or do a conjunctival autograft along with the phacoemulsification. Here I am just showing you the phacosurgery alone. So it's a clear corneal incision at the, on the temporal side, and you can go ahead and do the regular phaco. A few things that, like I said, you have to remember is that the area where we have done a trabeculectomy, in that place, if you notice, the area where the PI is there, you never see zonules in that place. Zonules are usually absent. So that means if you have a large area of trabeculectomy and a large area of filtering bleb superiorly, you can have a compromise of 1 to 2 clock hours of zonules in that place. So be careful that you may come across either, if it is a degenerated vitreous, sometimes you may come across vitreous, but it's very, very unlikely if you don't go and disturb it. But most often, zonular weakness is something that we need to remember. And if you're using a blue or a dye in these eyes, blue can actually go through this and it can stain the conjunctiva. That's not going to really harm, but we don't know what its effect is on the bleb. That's something that you need to remember. Whatever technique is suitable for you to go ahead and do a phaco, do that. And once you finish that, like we said, you would like to definitely suture that wound because you have a leaky wound superiorly. So most often these eyes can be associated with little rise in intraocular pressure. So if I operate a patient with a pre-existing bleb, if I do a phacoemulsification, although I have removed the viscoelastic thoroughly, you don't want to leave it, but I still would prefer to, if it is a one-eyed patient especially, I would prefer to give a Diamox if the patient is not allergic to a sulfa drug on the day of surgery, because post-op spike is something that you would want to avoid. And post-operative inflammation, we definitely want to try and reduce as much as possible. So good usage of steroids in the post-operative period and cycloplegics is something that you would want. So most often we also encounter eyes like this, which is not at all uncommon for us, and especially if, like I said, if they are on pre-existing pilocarpine usage for a very long time. Then we end up having small pupils like this. So a couple of things that will help us to manage this pupil is that I do a single site phacotrabeculectomy most often. My triangular flap size is relatively large. It's 4 into 4 millimeters. And after I make the flap, I use mitomycin. And once that is removed, so I finish doing all of that before I enter the anterior chamber. So then I make the paracentesis because I don't want the mitomycin to be used when I have opened up the eye. So this is using Kuglin hooks to dilate the pupil. So even if you get about 5 millimeters of pupil size with this kind of a cataract, I think it is pretty much okay to manage. You can use the iris hooks as well, but I generally don't like to use them because you have to make 4 more side ports, and you already have 2, and then you have 1 more incision there superiorly. So the lesser it is, the better it is for me. Then direct chop is a technique that I generally use, so go ahead and do the cataract surgery the way you would normally do. So pupillary stretching either with iris hooks or just a visco expansion itself, using a high viscous viscoelastic to go and dilate the pupil a little bit. Even if you get about 5 millimeters, you should be able to manage unless it's a very hard cataract. And I use an MVR blade to make the deep block and do a iridectomy and close the scleral flap. So scleral flap is usually a single suture to the scleral apex of the scleral flap. And I have used air here, possibly because maybe there was a small Decimates detachment superiorly. So this was a one-eyed lady with a very hard cataract, and central vision had dropped significantly, and to, I think it was counting finger 3 meters. And other eye also she lost after a cataract surgery. So she was very, very skeptical, and that's possibly one of the reasons why she waited for a very long time before she actually came saying that she had a problem. So this lady, we were doing it under topical anesthesia. A little bit of subconjunctival or subtenons will help. So I was just showing you a technique where a small pupil is not a contraindication for a topical phacotrabeculectomy. You can stretch the iris, you can do all of that. provided you use an intracameral anesthetic. So what we use is, it has to be preservative-free. Anything inside the eye has to be preservative-free. Loxicard or Xylacard or ropivacaine, any of these that are preservative-free that we use for intracardiac use is very safe to use intraocularly. Once you do that, after that, if you stretch the pupil, whatever you do, they are so cooperative, they will have actually no pain. So you can go ahead and do whichever technique you can. Because the pupil was not very big, and I preferred to do a direct chop, so that's still okay. You can manage. It's a little harder cataract. And you close the wound. So this was in an eye with a subluxated lens. You can actually see the gap between the iris and the lens margin. A patient with pseudoexfoliation, it's an immature cataract, but there's a gap between. So whenever you are operating a patient with pseudoexfoliation, so you can see there's a gap there inferiorly. So close to about 5 clock hours of weak zonules is what is present in this patient. So the choice was two. One is go ahead and do a phacotrabeculectomy and phaco without manipulating too much and making sure that you're not causing too much of a zonular dehiscence in the process of your surgery. So like I said, a good hydrodissection, a large rhexis, a good hydrodissection, and a direct phaco chop is something that helps me. And once you finish, if you have too much of a zonular loss, and if you think there is a decentration, you can use a CTR ring. If it is not, you can use the regular, the intraocular, foldable intraocular lens itself. Place it in such a way that the haptics are placed in the direction of the zonular loss, so that it causes maximum stretch in that area, and there is no decentration of the pupil. So large rhexis for two reasons. One is it causes minimum traction on your nucleus rotation and your nucleotomy procedure. Second thing is that these eyes are also more prone for capsular phimosis. So that's something that you would want to avoid, and any decentration after that. So like the more number of implants that we do these days, just like how you have blebs and you have to go and do a phaco in these eyes, we also have eyes with tubes and we have to go ahead and do a cataract surgery. It's not in any way different to do cataract surgery in these eyes. You don't have to go and block the tube or any of those things. So you have to just go ahead and do a regular cataract surgery. Make sure that you're not making your incisions or your side ports anywhere at least 2 millimeters around the tube area. Don't disturb it. And when you do a cataract surgery, complete everything. Make sure that you remove all the viscoelastic that is remaining there, and there's no tube block at the end of the surgery, and close the wound. So this is somebody who has significant amount of cataract and significant conjunctival scarring. This is a combined cataract extraction with an implant. So normally we fix the implant to the eye before I go ahead with the phaco, and just make sure that the tube is left in the subconjunctival pocket. Go ahead and finish your cataract surgery. Once you do that, then inserting the tube will be helpful. Otherwise, once you insert the tube, then during your phaco procedure, too much of fluid is leaking out of the eye and the conjunctiva balloons up, so it's very difficult that way. So you can combine, just like your phacotrabeculectomy, you can also combine an implant surgery along with cataract extraction. Thank you.
Tips about successful combined surgery. Trabeculectomy is a very simple surgery. What you need to do is to access the area where you need to do a trab. Make sure that the computer is working. Wait for assistance. Okay. So you need to access the area where you want to do the filter, do the trabeculectomy, get adequate exposure, make the opening, relax the flap, and make sure that the flow is patent. Okay, so actually it's not as simple as that, just to lighten the mood. What you need to do a good combined surgery is to first do a good cataract surgery, because a problematic cataract surgery will cause more inflammation, and that inflammation will not be just a matter of delayed recovery of visual acuity. That aqueous goes into the bleb, and that will cause more scarring in the bleb. It is important to aspirate the cortex completely, not only for preventing the PCO. It's important to put the IOL in the bag, not to leave the haptics in the sulcus and irritate the iris, and leave the vitreous into the vitreous cavity. If it comes up, reposit it back after a good vitrectomy. It is important also to stop pilocarpine and prostaglandin analogs before the surgery. And if the patient has been on a PG analog, please give NSAIDs after the surgery. It is very, very important to take care of the conjunctiva and to use a minimum incision that you want to make. Use a blunt subconjunctival dissection because you can otherwise go and cause a massive bleed and cut the conjunctiva or the superior rectus. And always hold the conjunctiva with a blunt tip forceps like a Pierce-Hoskin forceps or a non-tooth forceps. When you are lifting the conjunctiva, please just lift for adequate exposure. Don't pull the conjunctiva because that will increase the extent of incision that you have initially made. It is very, very important to have a posterior flow because anterior flow is what tends to give you thin cystic blebs in the long term, which not only are symptomatic, but also are prone to leak and infections. How to achieve that? To use a large triangular or rectangular flap and to ensure that the edges don't go up to the incision doesn't go up to the limbus. By doing that, you ensure that the aqueous doesn't go here, aqueous is directed posteriorly. You can also place a suture on the sides, which will have the same effect. And it is, I don't know, but I'm very, very scared of hypotony because if the pressure is high, I can do a massage, I can do a suture lysis, but if the pressure is low, I can hardly do anything. Also, hypotony is responsible for most of the complications like wipeout, hyphema, inflammation, and it is likely to happen when there is ciliary shock, when the patient has more inflammation, has been on a lot of medications. Use of strong cycloplagia and pressure control prior to the surgery is important. Ensure that there are no leaks and titrate. Now, this is a way of titration that I have learned from when Paul Palmberg visited us. We usually titrate the flow, look at how much the fluid is flowing through the flap. But it is always better to titrate the pressure and not the flow. So the sutures are locked after the initial three throws and not closed. So I used one releasable and one fixed suture. And at this point, just do a slight overfill, wipe off the excess fluid that is there, take a surgical sponge and wait for the point of time when you almost see no flow. Now, this is the point of equilibrium, and this is what the pressure is going to be later on when the conjunctiva is closed. Using iris repositor, just touch on the conjunctiva. At this point of time, you should have an easy indentation without any folds on the cornea and the descemet. So this is the point at which you want to titrate the your trabeculectomy. Use of releasables is a very, very important tool in avoiding hypotony. I use a loop releasable. What Dr. Debasis showed was an anchored releasable. So the entry is from the scleral side, goes onto the cornea, and then comes in, and then the releasable is placed here. So you see there is no hanging end of the suture. There is no windshield wiper syndrome. This is just an animation to show how it is taken. You enter through the sclera here, go under the cornea, leave this loop outside, go under the cornea again, come out over the top of the flap, and then make this releasable 4-loop suture here. So that is how a loop releasable works, and there will be no hanging edge. Now, I use mitomycin for most traps because most combines because combines are associated with more inflammation. This is just a hypothetical situation. What happens when you do a trabeculectomy on the day one? The conjunctiva will be very flexible. There is no fibrosis there, and you have a good bleb. The amount of flow through the flap is determined by the tightness of the suture and the amount of apposition that you have, so it will be a good flow. So you have a good raised high bleb and a good flow with a pressure of 6. What happens then onwards is that gradually the conjunctiva starts fibrosing, and the flow here is constant. So the pressure becomes quite normal at week 1. Later on, 2-3 weeks down the line, the bleb becomes even lower as the conjunctival fibrosis and the pressure within the conjunctiva is increasing. Your flow is still constant, the pressure rises further. And there will be a point of time because of increasing conjunctival fibrosis, you will have a bleb that is low or flat and a raised pressure. Now what can you do? You can prepare for it and avoid it right from the go. If you have a releasable suture which is relatively tight, have a less amount of flow through the flap here, the conjunctiva is still flexible, but you don't have a low pressure on the first day. It is important to avoid hypotony. So you have a good pressure. When the patient comes back for a week follow-up, what happens is the amount of fibrosis increases, and you do a bleb massage and raise the bleb. 2 to 3 weeks down the line, you can take off the releasable and increase the amount of flow here which will compensate for the increase in amount of fibrosis that you have in the conjunctiva. You can further use 2 releasables or as many as you want, and use of mitomycin allows you to modulate the flow, and the conjunctiva will remain a little flexible and the fibrosis will decrease with mitomycin, and you can manipulate the bleb up to 4 to 6 weeks. Now, it is very, very important to use a large area of treatment when you are applying mitomycin. Use multiple soaked sponges or a collagen shield spread over a wide area when you are applying mitomycin, and apply it anteriorly as well as posteriorly under the flap is also a very, very good idea. Because if you don't do it, you will have a thin cystic bleb if you apply it only anteriorly, and you will also get a ring of steel which typically lies at the junction of the mitomycin infused and non-infused area. So that is where the ring of steel appears. You should always seal with certainty and have a watertight closure. You can use absorbable vicryl sutures or non-absorbable sutures, wing sutures, and mattress, and try to have minimum discomfort due to the suture. Now, I use the Moorfield's safe surgery system to close the wound. So there are corneal grooves here, 3 corneal grooves. So the entry is through the corneal groove, and then I have 4 to 6 throws here, a purse string kind of a thing, and then the exit is through the same groove. You need to pull the 2 ends together, and this will pull the conjunctiva towards the edge of the limbus. Now, this closure is right at the limbus. It does not go into the cornea. It's there at the limbus, and that creates an apposition with the natural landmark. So there are 2 sutures at the edge which need to be purse string kind of suture. And if the incision is not very large, the central suture can just be a single horizontal mattress suture. And this gives you a closure continuously along the thing. Now, what is different from other techniques of closure here is that the direction of pull on the conjunctiva is downwards. So it not only opposes the conjunctiva, it also prevents it from retracting backwards and upwards, because the strength is derived from the cornea, which is the strongest thing that you can anchor the suture to. And in my experience, it gives a very, very good closure, a perfect closure. So in a nutshell, do a good cataract surgery, which I'm sure everyone does. Handle the conjunctiva very gently. At the buttonhole is beginning of most problems if it is at the wrong place. Have a flap that is designed to direct the aqueous posteriorly. Use wide area mitomycin wherever it's indicated. Use releasable sutures to avoid hypotony. Titrate the intraocular pressure, not the flow. It's more objective, and have a watertight closure. Thank you.
Thanks, Dr. Siddharth. And now it's up to Dr. Sirisha Madam for the concluding part of our program, which is the post-operative care.
Do we have 5 minutes or 10 minutes? So after doing a good combined surgery, we always want a perfect balance of intraocular pressure. We don't want it too low, we don't want it too high, and I don't think it's very easy to achieve. So we create a leaky wound, and we create a hole, and we don't want it to close. I think that's the most unconventional thing that we can do for anything in the human body. So you want a hole, and then you don't want it to close, which doesn't happen. It's very natural for the body to try and recover whatever injury we have done. So it tends to close. So we do use mitomycin, we do use a lot of antifibrotics to prevent that. Aqueous itself, if it is flowing very well, that itself prevents closure. So we have to achieve a balance between the two. In the post-operative period, many people actually come and ask this question, day 1 post-op trab or combined, do you check intraocular pressure? Of course, we check intraocular pressure. Which instrument do we use? We use applanation. So any instrument that you use, whether it is non-contact, whether it is applanation, whether it is eye care, whatever it is, I think it's important to do because you will see what is the importance of doing the intraocular pressure on day 1. So we check it every visit of the patient. You have to look at the way the bleb looks like, look at the anterior chamber depth, and look at the intraocular pressure. So these two you can examine under slit lamp, and IOP is something you definitely have to check. So is the bleb elevated? Is it flat? Is it leaky? And over a period of time, you also have to look for its vascularity. And depth of the anterior chamber, is it deep or shallow? And is the pressures low or high? Why is it important? Because if you come across a patient who has day 1 or day 3 shallow anterior chamber, you can have multiple problems. It can be associated with multiple problems. Unless you figure out what the cause is, you will not be able to treat it appropriately. So shallow anterior chamber with low pressure, shallow anterior chamber with high pressure. If it is low pressure, usually it is related to a couple of things that we will come up to. If it is high pressure, then you manage them completely differently. When do you reform the anterior chamber? Again, this is something that people keep asking. I have a shallow anterior chamber. I have an iridocorneal touch. I took it up for AC reformation today. And 2-3 days later, again the AC is shallow. You took it up for AC reformation again, and the second time you have left viscoelastic in the anterior chamber. Why do you do that? Unless you figure out why you have a shallow anterior chamber, first of all, if suppose it is just an overfiltration, you handle it different way. If it is because of a leak, you handle it different way. If there is a conjunctival buttonhole, you handle it different way. If you have a choroidal detachment, you handle it different way. So depending upon what the cause is, you will have to treat the cause rather than just going and doing an anterior chamber reformation, because you have to remember every time you take the patient up into the OR, it's not just you that you're worried. The patient and the attendants are going to be extremely unhappy about it. So although it means it's a simple procedure, but you have to take the patient back to the OR, and I think we need to be careful. So it's not uncommon to see a overfiltering bleb in the first couple of days, which Siddharth very beautifully demonstrated that you don't have a resistance, so amount of flow that's going in just elevates and balloons the conjunctiva. You have a large filtering bleb. So if it is just an overfiltration, if CDLS is negative, if you have a shallow anterior chamber and low intraocular pressure, all you have to do is just wait and watch. Put them on cycloplegics, which is the most important thing. Put them on cycloplegics and very closely follow up. Make sure you give these instructions to the patient. I take close to 5 to 10 minutes to explain every single post-operative trabeculectomy or a combined patient as to what they're not supposed to do. When you're putting the drops, you shouldn't touch the upper lid. Don't squeeze your eye. Don't rub your eye. Wear a cap at bedtime. Don't strain, whether it is cough, constipation, whatever it is. You try and avoid staining. I think these things go a long way, because they come back and say, you never told me this, if they have come back with a sudden problem in the post-operative period. So taking care of all of that, I think just an overfiltering bleb will heal by itself. If you have a shallow bleb or a flat bleb and a shallow or a flat anterior chamber and low intraocular pressure, and if you have a leak, unless you go and fix that leak, you're not going to help this patient. So that leak can be fixed either with a bandage contact lens or with a suturing, depending upon what the problem is. You can have all of these either with an overfiltration or with a leak associated choroidal detachment. So something that is pushing from the back, unless that resolves, your anterior chamber is not going to deepen. Again, treat the cause and make sure you put the patient on cycloplegics. I generally don't give systemic steroids for patients with choroidal detachment unless there is a suprachoroidal hemorrhage, because if you have hemorrhage, that is very toxic to the overlying structures and the retinal, especially if it is submacular or something like that, you would want to treat it. Otherwise, inflammation itself will induce more of choroidal detachment. Other than that, if it is serous choroidal detachment, we don't use it, but usually it happens if you have ruled out leak and things like that. Just step up the topical steroids, and cycloplegics generally help. Management of low post-operative IOP, like I said, all these causes, most often it is conservative management and they are fine. If you have any of these, either you have a leak or you have a hypotony with a maculopathy or you have a kissing choroidals, you better have to intervene it. So either it is a bandage contact lens or a suturing of the leak, or a bleb repair if you have a overfiltering bleb which it is not settling down in a couple of weeks, or a choroidal drainage if it is a large leaky one. Like I said, we have to check the intraocular pressure. So if the intraocular pressure is high, two things that can happen is there is malignant glaucoma or suprachoroidal hemorrhage. Suprachoroidal hemorrhage is not so common, but malignant glaucoma with the kind of angle closure eyes that we operate are not at all uncommon. So this is something that we need to remember. And also, just a word of caution that every malignant glaucoma need not have high pressures. To begin with, you can have a shallow or a flat anterior chamber, no bleb leak, no filtering bleb, no choroidal detachment, but your AC is very shallow or flat. It can be malignant glaucoma, even if your pressures are 7 or 8. It can happen, so just start with cycloplegics. That will take care of most of the problems. B-scan is something that will help you to rule out if there is a suprachoroidal hemorrhage, which will appear like this. And post-operatively, like I said, you have to put them back on conservative management. So cycloplegics associated with mydriatics and topical steroids is something that is very useful, and that can take care of the malignant glaucoma. So you can have shallowing of both central and peripheral anterior chamber and presence of a patent iridotomy. That's something that you need to really make out. Sometimes we've done an iridectomy where the posterior flap is still remaining there. So you have a pigmented layer still remaining there. If that is the case, you can just go and YAG it. So you have to rule out the pupillary block in these eyes before you call it as a malignant glaucoma. In the presence of a malignant glaucoma, how we can manage it, there are multiple things, either it is medical or laser or a pars plana vitrectomy with an iridozonulo hyalodovitrectomy. And if you have a suprachoroidal hemorrhage, like I said, we have to be very, very careful. Sometimes this can happen intraoperatively also, but preoperative mannitol as well as reducing the intraocular pressure to a great extent in the preoperative period prevents this complication. So you can have a shallow anterior chamber, high intraocular pressure, loss of red reflex when you do a B-scan. So fundus can be visible like this. And if you do a B-scan, you will be able to see hyperechoic lesion in the posterior segment, where usually it is serous, it is just echo-free. If it is echogenic, hyperechoic, then that means you have some fluid, the hemorrhage there in that area. Again, it is conservative management. Here I use oral steroids. If it is associated with retinal complications, only then you will try and drain it, or if it is persistent or kissing, then you will want to go and drain it. Otherwise, generally conservative management helps not just resolution of suprachoroidal hemorrhage, but also helps you to maintain your bleb. This is one such example where we had a suprachoroidal hemorrhage in a patient with Marfan syndrome post-trabeculectomy, but on conservative management alone, he regained 20/25 vision and with a good filtering bleb. So if, like I said, to summarize, you have to look at the characteristics of the bleb, look at the anterior chamber depth and the intraocular pressure, understand what the causes and treat them effectively. Just a couple of cases to know what happens in the post-operative period, how to identify a failing bleb and how to treat it. This is an elderly lady who had a primary open-angle glaucoma, underwent a trabeculectomy with mitomycin C, and 5 weeks post-op, patient was stopped on steroids, and 5 weeks post-op, this is the kind of picture. You know, it's an angry-looking bleb, it's localized, it's extremely fibrotic, and the pressures are on the higher side. So these are something that you also always have to keep a watch. If you see somebody like this, then is this failing? Of course, yes, the pressures are slowly going up. This is after you have done a gonioscopy. You need to rule out that the ostium is patent and things are fine there. So if you have something like that, step up the steroids. You can use 5-FU injections subconjunctivally weekly for 1, 2, or 3 weeks, depending upon how the eye is behaving. Or if none of those things help, needling with mitomycin C is something that can help as well. This is a young patient, juvenile open-angle glaucoma, underwent glaucoma surgery, and this is the intraocular pressure with 12 millimeters of mercury with a large diffuse bleb. But when the patient came back by about between 2nd and 3rd week, this was the kind of appearance. The conjunctiva was terribly congested. There was watering. This is one more thing that's very, very important. Whenever a patient comes and tells you there's excess watering in the eye for the past few days, that means you have to look for a leak. Invariably, I met to see a patient who's come and told me that they did not have watering and they had a leak. Very, very unlikely. Even if sometimes your pressures cannot tell you correctly. Pressures can be 14 and 15. You may still have a low flow leak or a leak intermittently whenever the patient tries to squeeze or on pressure. But watering is something that is consistently present. So this patient had watering and the bleb was congested and flat. If you see this, there is some amount of necrotic tissue here. And patient had a bleb leak. What could be the cause and how would you manage this? So it could be an excess cautery that you have done to the conjunctival edge where you have not taken precautions to pull the conjunctiva away when you're doing the cautery, or you have applied mitomycin C but you made you have not made sure that the edges of the conjunctiva are not exposed to mitomycin. That means the edges of the conjunctiva should be pulled away from the mitomycin exposure. Otherwise, the edge itself can start having a necrosis and an ischemic bleb or blebitis. These are three things that we can think about. And something that actually helps us in the early post-operative period is doxycycline. Oral doxycycline, if you think your conjunctiva is not okay, has some kind of an appearance like this, or if you have a very abnormal looking conjunctiva or very unhealthy looking conjunctiva, doxycycline is something that helps. It helps to prevent collagenolisis. So it prevents collagenolisis. It helps the bleb leaks to seal faster. So 100 milligram twice daily for 2 to 4 weeks, depending upon how the eye responds. And this patient, we couldn't place a BCL because the conjunctiva was not healthy. So we started off with treatment initially with medications, and once it settled down, then we placed a large diameter BCL. And always, whenever you use, when I say large diameter BCL, what we normally use is bandage contact lens is 14 millimeters, at least 15.5 millimeters, so that it covers the peripheral edge of the conjunctiva. So it has to cover. It actually gives a mechanical tamponade so that the conjunctiva, so whenever your lid movement is there, it doesn't go and rub on the tissue and it doesn't let the conjunctiva heal otherwise. So that it helps. I leave it in the eye for 2 weeks, continue the patient on topical antibiotics until that time. Usually after 2 weeks, when I remove the bandage contact lens, it's healed very well, bleb is beautiful, and you can continue your routine post-operative care. What is very important when you place a BCL is always make the patient sit for a few minutes and then call the patient to see again, because sometimes this can happen. You can have the BCL sitting under the conjunctiva and the conjunctiva is overriding the BCL. That's a dangerous situation. If you have something like this, you can't leave the BCL on there. This is only going to cause more problems. Then you also have 18 millimeters, you have 20 millimeters bandage contact lenses available today. The scleral contact lenses available today, they're about 1,200 rupees or so, which is extremely useful, especially for somebody who's done a conjunctival incision, which is slightly posterior, 2 to 3 millimeter frill. And if you have done a trabeculectomy, even in those eyes, you can use these lenses. They're extremely useful. So this patient, after 20 days of oral doxycycline and BCL, had a diffuse bleb and 14 millimeters of mercury pressure, no leak, and at 1 year post-op, this is the kind of conjunctiva. So not always you need to take the patient back into the OR. Extremely rarely we take the patient back into the OR. Most often you will be able to manage, but only thing is that you have to see them more frequently. Like I tell my patients, like if I do a trab or a combine, surgery is just 50% of the treatment. How you manage it in the post-operative period is something that can help us to save this bleb for a very long time. And I think that investment is worth giving it both for the patient and for us. Thank you. So if you have tight sutures or releasable sutures, you can try and do a suture lysis, or you can release the suture in the post-operative period, and that also helps to control the pressures. Thank you.
All of you who have attended this program, thanks to Dr. Anil Mandal, Dr. Sirisha Senthil, and Dr. Siddharth for the presentations. Thank you.